I am thrilled to be here, and I'm so thrilled y'all came. So my presentation today is trying to focus on just understanding a little bit better what palliative care does and how we can help. I know that there's a lot of misconceptions about it, but I really think that it's the best specialty. Um, I did my medical school here in Texas in San Antonio. Then I trained in residency in adult medicine, internal medicine in Oregon. And then I went down to MD Anderson to do my fellowship in palliative care. So really the population that I feel like I know the best is cancer and symptom management. So today we'll learn about what is palliative care, what do we do, as I'm going, do feel free to make this a dynamic conversation and throw questions up in the chat or in the Q&A, and we'll just answer them as we're going. So with that, all right, so as all of you have personally experienced, serious illness just affects every aspect of our life and of our identities and how we function in the world and how we have to suddenly shift all of these things. And so it affects our physical states, it affects our mental states, it affects absolutely our emotional well-being, it affects our spirituality, 100% affects our financial ability to either bring in income or how much it costs for our healthcare. It impacts our family, our spouses, our children, our parents, our everybody around our community. It impacts our friends and how much willingness tolerance they're willing to sit with and watching their friends struggle. And for some people, they really swoop in and come and support you. And for other people, they just can't do it. And a lot of times patients share that they feel abandoned by their friends and community. So it impacts all of these things. It's not just, oh, I have a cancer in my breast and that's all I'm dealing with. It's everything. So oncology is really fantastic about treating cancers, but palliative care, I think, really focuses on the everything else-ness about it. And one of the integral pieces of palliative care is that it is practiced on interdisciplinary teams. So while I, as a palliative care physician, can do a lot, I'm a single human being and I'm just a doctor, and I don't have the specialties of all these other people that I work with on my teams. So if you look at this picture rather, there's, kind of a patient in the middle, and, we have physicians, we have nurses, we have chaplains, we have social workers, pharmacists, and I put therapists, and that can be like a physical therapist or occupational therapist or a counselor, all of these kinds of different members of a palliative care team that tend to try to surround the patient with the different kinds of support that they may need at different points in their journey. So major barriers to palliative care. A lot of times doctors in particular have the impression that palliative care is only appropriate at end of life. And that's an old misconception that I often have to try to fight against. People think that palliative care automatically means hospice, and that is absolutely not true. And a lot of physicians worry that if they refer their patients to palliative care, then patients might think that their doctors are losing hope or that they'll cause the patients themselves to lose hope. And that's obviously not what any oncologist wants to do. But when you have patients in particular, that, don't really know what palliative care is, when we've read them the definition of what palliative care is, most people are like, wow, that sounds really great. We should definitely do that. And so here's the actual definition. CAPC is the Center for the Advancement of Palliative Care. It comes from it's a big national organization. And so this is a bunch of words on a page, but I've highlighted, serious illness. And it's really whatever the diagnosis is. It can be at any age. It can be at any stage. And palliative care absolutely is done alongside curative treatment. So just because I'm in on a patient's case, it doesn't mean that we're not hoping for a cure in this particular case. So done alongside curative treatment. The focus of the work is working on relieving symptoms, improving quality of life. It's both for the patient and the family. And I really think of the whole patient and family system as being part of the people that I am trying to treat. It's practiced by a team, like I talked about earlier. And really, we're just there as an extra layer of support. And what that looks like depends on what the patients' and families' needs are. And so this is the old model of care, of what, people used to think of, like we do life prolonging care. And then once we're at the very end of life, there's hospice and that's it. But now we have this kind of new model where we're doing life prolonging care and palliative care alongside with it, because like we talked about at the beginning, serious illness impacts all these aspects right from the very beginning. And because it changes so much, I think that patients often need and absolutely deserve to have this extra kind of support to make their life and all of these transitions that they're going through just a little bit smoother. And while this is kind of a straight line, diagonally cutting through life prolonging care and more palliative care, I really think of this line as just like being a roller coaster up and down in the middle, because there are times when I'm very involved in the beginning and then in the middle taper off, and like just depending on what the needs are, we shift how much I see my patients, and we'll stretch it out if everything's just kind of copacetic. So it's a model. It's not a perfect model like most models. And so what are some of the symptoms that I, as a palliative care physician, what do I treat and what do I manage? Pain is probably the most common reason that people get referred to me. But once I have people on my service, I'm pretty darn thorough in the things that I'm trying to address and help them with. And so pain, nausea, constipations are a huge one. People's appetite. Do you feel short of breath? Fatigue is a big one. Drowsiness, different than fatigue. Like fatigue is just that, like, I can't like get up and have the energy to like help take care of my kids or walk outside. And drowsiness is like that feeling of like, I'm falling asleep when I, like, as soon as I sit down, and they're different. Working with sleep disorders, anxiety, depression, absolutely working on advanced care planning, family conflict, what your ideas of like how you want treatment to go and what the family's ideas of how they want treatment to go don't always align. And so helping people's voices be heard more, and trying to navigate some of that conflict is part of our goal as well. And sometimes what you want for your treatment and what your medical team or what you think your medical team want are different too. And so a lot of times palliative care is helping negotiate cancer treatments or other kinds of treatments with the primary medical team, and smoothing out any conflicts that might be arising in that space as well. And some people say, like, what's the difference? I have an oncologist that treats my pain versus palliative care symptom management. And here I would just say that it's kind of the difference between like your primary care doctor managing heart disease versus a cardiologist. And so a lot of oncologists can be great at doing some symptom management, and a lot of primary care doctors can be great at managing, heart failure symptoms. And I have further expertise because I've just done this kind of training, and this is like my entire focus of how do I manage hard to control pain and hard to control symptoms, and how do I make that better? And, oncology visits are often really quick, and there's so much to cover in terms of just what is the cancer doing and how do we best treat that? Like, I have the time and space to focus on what's going on in your life and what's keeping you from living the best life that you can be. Because my goal is just to help people live the longest, best life possible. I mean, what kind of a great job is that? So being able to devote all of my time to that kind of focus just allows us to go a little bit deeper, try different things, make sure that we have an agreement of like what I think might work and what's going to work for your life. Because a lot of times there's a lot of different ways to manage these symptoms, and we can talk about the different pros and cons of each particular thing. So that's a little bit about, if you have symptoms and your oncologist is doing a great job of managing them, then no, I don't think you need palliative care. But if you're having more distress, then palliative care can be a really great added benefit. And then the other thing that I always am working a lot with is that because I have this kind of broader view of patient care and the holistic process that is just trying to be a human while you're suffering with cancer or working through all the cancer things, I have a lot of resources in the community that I am looking out for and reaching out for to make sure that I can connect you to. So I have my team that like kind of focuses on the individual patient, but there's a lot of stuff that I can't address individually that I know that I can refer out to give more support. And so, when people need more counseling, because just trying to do these internal struggles of like becoming a person living with cancer a lot of times requires extra therapy. And the Flatwater Foundation is an organization in Austin that's fantastic. It focuses specifically on providing therapy for patients with cancer. And they also do a lot of like discounted therapy to reduce the barriers so that patients can actually get the mental health support that they need during this particular time. So I do a lot of referrals to the Flatwater Foundation. A lot of families worry about, how is this diagnosis impacting the kids? How do I talk to them about it? If you have children and you have a cancer diagnosis, Wonders and Worries is one of the best things to come to Central Texas. They're a fantastic organization that helps families work with their children. And I can't say enough good things about them, but I've never heard anybody sad that they've ever gotten involved with the Wonders and Worries programs. It gives the children different like means of support. It helps with their grades. It helps with the children's anxiety. And it helps the parents find different tools to be able to talk to the children so that they can each support each other. Because what I see a lot of times is that children are scared but want to be strong for mom and dad are like trying to be strong for their children, and then a lot of people are not talking to each other and not as supportive as what it could be. So for financial distress and resources distress, I'm very connected to case managers and social workers. Questions about integrative medicine, I get a lot of those from my patients, wondering about like massages and, is this Chinese herb a good thing to take? And so that's another, like, there's a whole integrative medicine specialty that looks at like kind of non-Western traditions and like how do we integrate them into our cancer treatments, because they are really effective. There's a lot of great things out there, and there's a lot of snake oil. So what's the like right thing to do? So I work really closely with like pharmacists and other trusted professionals in our community. And then also, like I said, when there's family tension, we help set up family meetings to coordinate the care and try to help get everybody on the same page as much as we can. So that is an overview essentially of what palliative care does and kind of basically what my job is. And
Dr. Mills, one question that came in, and I'm not sure she didn't answer, but I think she was asking, is Wonders and Worries national, or are they just local?
Wonders and Worries, as far as I know, is a local and expanding program. So I am sure that they're in Austin. I know they are in Houston now. I don't know if they are outside of those two locations. Great question.
Great, thank you. Okay, so let's get to some of the questions. So one of the first questions that came in was, what factors determine when to provide palliative care?
Great question. So one of the biggest factors I would say is just when you start feeling like you are having symptoms that are not well managed, and that could be any kind of symptom. So just like through that list, or just if there's more distress that your oncologist doesn't have time for and you feel like you need so like some extra layer of support, a palliative care provider is a great place to start, because they will be thinking about these things in a very holistic manner.
Great. Along those lines, how does someone access palliative care? And she's asking, how is it paid for?
Also a great question. So in like the easiest blanket statement is ask your oncologist for a referral. There are different programs in different cities. I know here in Austin, we have the Austin Palliative Care home visit program. And there's an organization that's called Hospice Austin, and they used to be just hospice, that they've expanded to now have a home palliative care service where they will come to your house and meet with you there, so you don't even have to go anywhere. And I believe that you can actually just refer yourself to that. And I can put the organization in the chat so people can Google it. Austin Palliative Care. But for those that are not local to Austin, I would say ask your oncologist, can I have a referral for palliative care to address whatever symptoms?
Great. Another question that came in was, I have my first appointment with a palliative care doctor tomorrow. What questions or requests should I make so that I can make the most out of my appointment? I think that's a good question.
That's a great question. And I definitely have patients all the time, like about half of them show up and they have like very specific, like pain, nausea, things that they need to address. And about half of them have been referred to palliative care and they have no idea why or what it means. So both are very common. And the best thing that you can do is just think about, like, in this list, where are you struggling in your life? You know, is it your sleep? Is it your fatigue? Is it your most worried about your children? Is it that you have anxiety and it's keeping you from sleeping? Like, what are the things that are making your life particularly hard right now? Bring that list. And then also, palliative care doctors we get a lot of training in communication. So we should be pretty good, hopefully, at asking questions that are going to draw some of these things out and listening. It's one of the things that I feel like our specialty kind of prides itself on, is being able to hear what's going on and listen to you and what your needs are, which I don't know that doctors are always the best at that.
Well, one follow-up question I wanted to ask was, and actually it was something that you mentioned in the when you were talking about your whole team. The whole team, but do you actually coordinate all their other medical issues? So with their other doctors,
great question. Like
whole coordination.
When I say I coordinate, like a lot of times I will contact, and like, especially if there's something important to share, or like I need to know what's going on in their cancer treatment to have a good understanding of like, where are we heading in terms of like prognosis, and how do I best prepare the family and the patient and everything, and give them extra support they need on any part of their journey. So that kind of coordination, but like, I'm not going to generally be making appointments for people or getting rides. Or is that your question?
Yeah, and I think more like case management type, you know, if they're seeing a cardiologist, if they're seeing, you know, pulmonologist, you know, other specialties.
Yeah. So
then they're oncologist.
When I say care coordination, I think of it more in the sense of like making sure that the whole care team is kind of on the same page of, if I'm hearing something from the patient that's important that the other physicians need to know that's going to impact their treatment, then I coordinate that kind of care to make sure that we're all on the right track, taking care of this person.
Great. We do have another question, two questions. My oncologist was not receptive to palliative care when I brought it up. Can you advise how to have a better discussion with our providers?
Yeah. I'm sorry first. That stinks. And it's just an old entrenchment. I think one of the better ways is just, one, know that you get the right to advocate for yourself and just be like, listen, I just want to go and see a palliative care person because I'm struggling. Like, if you can give them some kind of like symptom or like a reason that you're struggling, like you shouldn't have to, is like what I'm railing against right now. Just like, if you say you want to go see a palliative care provider, like just refer. But if you were to approach an oncologist with be like, hey, I heard that palliative care is really good at treating X, Y, and Z, and I feel like I'm struggling in that place, that would probably be really helpful. I would say also, if you maybe bring up some more of the like emotional, spiritual aspects, oncologists might feel like they could handle pain and nausea. I would imagine that the emotional and spiritual is not something that they're excited about managing in their own practices. So that might be a tact. And I'm sorry.
Yeah. Okay, great. Hopefully that helps, Annie. Okay, so we have a question. Do you know if Texas will be expanding medical marijuana to stages 0-3 forms of cancer in the near future? And a follow-up is, regarding the marijuana, is there any research on effects, negative or positive, on ER positive breast cancer?
Both good questions. I don't know what's coming down the pike. I assume that Texas is going to be moving kind of it feels like the direction of the country is moving towards making marijuana more and more accessible to people. I would say the research around marijuana use is wildly mixed, and that when we look at it on a population basis, marijuana doesn't seem to help a lot with nausea, pain, anorexia, a lot of the things that it's supposed to. But when I talk to my individual patients, I have some patients where it doesn't help at all. And I have plenty of patients that say, like, this helps better than anything else that I can prescribe. And so what I really think the mixed results mean is that there's probably a subset of population that it's amazing for, and we really need to be using it more. And I don't know how to identify, we don't know how to identify those patients of who are really going to benefit yet. And so my hope is that we can continue to expand who has access to this medicine that can be really helpful and powerful. And stage 3 cancer can still have plenty of terrible symptoms. You don't have to be stage 4. So that's kind of what I would say for that part. And then in terms of research around the effects, negative or positive, for ER breast cancer, I don't know breast cancer specific research around marijuana. But like I said, the symptom wise, it's a very mixed results. I will say that there are also some very preliminary studies around using marijuana and like if you're taking other opioids, that like the metabolism of marijuana and THC does sometimes change the metabolism of opioids. And so like if you're using really high doses of marijuana, that's something that you have to definitely be telling your doctors if they're prescribing you opioids.
Great, thank you. Is occupational therapy a part of palliative care?
Totally can be. And when you work at some places, it's actually an integrated part of the team, and it's super helpful. And it's not something like, so there are some things that are just like kind of core palliative care that like almost everybody has, like you almost always have a nurse and access to pharmacy and things. I don't necessarily always work with occupational therapy, but when you have a palliative care specific occupational therapist or physical therapist, they are gold.
So along the lines still of sort of treatments, symptom type things. So someone asked, she would like some suggestions for joint pain and hot flashes.
Yes, 2 slightly different things. So the joint pain, I think that I would definitely want a little bit more information about like what kind of joint pain, because sometimes it's like anti-inflammatory, sometimes it's like we all have some amount of arthritis, usually by the time we're getting diagnosed with cancer. And then like the cancer itself causes more inflammation that like flares up that joint pain more. So sometimes it's kind of more like treating your arthritis a little bit more rather than like, but it can also be like chemotherapy is affecting my joints differently. So sometimes it's anti-inflammatories and NSAIDs, if those are safe to take, and talking to your providers are a really good thing. A lot of times physical therapy is wildly helpful for joint pain. And so I always recommend a physical therapy evaluation. In terms of hot flashes, definitely want to work with like whatever, need to know your regimen of medication that we're taking for the cancer. But venlafaxine is usually my first go-to medication. It's one of the most effective for treating hot flashes. And for most people, it reduces both the severity of the incidences and like way cuts down on the frequency by like 50 to 75%.
What was that again, that medication?
The name is called venlafaxine. Its other trade name is Effexor.
Great. And so some more treatment specific questions. Someone would like specific types of creams for face, body sores, or mouth sores.
Yeah. So mouth sores are really common in cancer treatment from like radiation or sometimes from chemotherapy, and they are miserable and sometimes just really severe. And sometimes it's thrush. And so like getting an evaluation, always an important first step. And so if it's thrush, then it's an antifungal thing. And it's thrush is very normal. Like we all have fungus in our tongue. but just when we're messing with their immune systems or sick or going through a lot of things, then it like overgrows. For the mouth sores that are caused by like radiation and chemotherapy, there's a couple of things. There's like a viscous lidocaine that numbs things, and magic mouthwash, which is a mix of lidocaine and some other medications. Both of those are effective, but very short acting, like usually lasts just a few minutes. I have some patients that just kind of sit there and like sip on it all day, but especially like when they're going to try to eat something, then they really need to coat their mouth, and that can be helpful. The other thing is sometimes you just need some stronger like opioid, even, especially if it's like radiation induced. That's a really common thing. And so opioids are not inappropriate for really severe mouth pain. For skin creams, if it's like open wounds, I have a really amazing wound care nurse, and I reach out to her on the regular, and she tells me which creams. But again, that's like a really appropriate thing to ask for like some extra support when you have wounds that you're dealing with.
So this one came in. How long can I expect the lymphedema I'm experiencing around the site of my lumpectomy to continue after my treatments were completed?
Yeah, that's a good question. Lymphedema stinks. There's so much about cancer that really stinks. This is one of those things. It varies. And for some patients, they do go back down to normal after like weeks and months. For a lot of patients, it's something that they battle with for the rest of their lives. And my best advice would usually, especially in urban areas, lymphedema clinics are the best thing that you can get involved in. And so they are 100% the specialists in how to treat lymphedema. They have like, you know, the pumps and like the sleeves and compression and everything. And so like, I definitely, when I'm dealing with lymphedema, have some basic things, but then I send to lymphedema clinic for anything that I can't provide.
Yeah. And so I would suggest for lymphedema, asking your navigator about some resources for some great lymphedema specialists. And there was another question about fatigue. I know you talked about fatigue, you know, some suggestions about how to beat fatigue and increase stamina.
Yeah. So there are some medicines, but I got to say the medicines are not like, fatigue is one of the harder things to treat because it's just so complex. And there's so many things that factor into it. So I really take fatigue from a really holistic approach. And so my thoughts about fatigue a lot of times are, you know, doing a really good history and finding out like, is it sleep? Is it pain that's keeping you awake? Is it anxiety that's keeping you awake and you can't sleep and you feel tired all the time? Is one factor that we really want to dive into and treat that well. And we want to use really good sleep hygiene. And I don't know if people are familiar with this term, but it's the idea that like everybody knows when you like are working with babies and stuff, like you want to have like a routine, and the routine kind of like tells their brain like, hey, we're getting ready for bed and you should go to sleep now. And that actually works on adults too. And so when we have a routine that we're doing the same thing at night, we can sleep better and we can let our brain relax and like kind of trigger it to like start producing all that good melatonin and help us sleep more, which will help fatigue. The other thing that pharmaceutical companies probably don't want you to know is that sunshine and exercise are really the best things that you can possibly do. And if we had a pill that was as effective as sunshine and exercise, like whoever makes that pill is going to be a stinking millionaire because it's just so good. And I know that's a big ask at times when you're overwhelmed and trying to balance everything else. Like, what am I supposed to do? And by exercise, I do not mean like go to the gym or like run 3 miles. I mean like walk around the block. Like just a little bit of movement is great for you. A little bit of movement outside is particularly great. Wear sun hats and sunscreen, all the rest of it, but like get sunshine in your eyeballs. It's amazing for mood. It's amazing for like helping regulate sleep. It's amazing for actually like has been proven to improve people's fatigue. And there's a comment in the chat. I recommend Angela for lymphedema and Gladys for physical therapy at the Cancer Rehab and Integrative Medicine. I don't know those particular individuals, but I appreciate the recommendations.
The recommendations, yes. And we do have many certified lymphedema therapists in Austin and around Austin. So, but yes, they are excellent as well. Here's another, back to the insurance question, but she added Medicaid. So Medicaid, Medicare, do you know how that works with palliative care, or do they see a financial counselor before?
Yeah. Who pays for the palliative care? So I forgot to answer that part of the question. Thank you for bringing it back up.
Sure.
It is generally billed as like any other specialist. So if you have the ability to go and see a specialist, which usually includes an oncologist, you can usually get a palliative care provider as well. A lot of oncology clinics have palliative care now integrated into their own clinics. And so a lot of times it's not enough palliative care and like they can be backlogged for a long time, but like that exists. In Austin in particular, I know I've got my clinic. There's one with Texas Oncology. I know that they've got some palliative care providers. The Austin Palliative Care, I am 100% sure, contracts with Medicare, Medicaid, all the major insurances. And the bonus is they also do the city insurance, which is the MAP insurance. And that's a big deal because a lot of the palliative care providers aren't able to do that. My clinic does, but I know that that's access is a problem.
I was in on a meeting the other night, and we were talking about palliative care, and someone mentioned not calling it palliative care, calling it supportive care. And someone agreed and someone disagreed. So can you speak to that a little bit? Because some people may have heard supportive care. And so maybe not understanding how those two work together.
Yeah, so they're literally the same thing. And MD Anderson used to be called the palliative care team. And then they changed the name to supportive care team, and their consults doubled. And I think it's just all in the name of like people have this association of palliative care equals hospice or end of life. And so doctors have a lot of those like resistances. And even though it was the same team of doctors doing the same kind of work, when they rebranded themselves as the supportive care name, all of a sudden it became so much more accessible to the physicians and probably to the patients as well, who might have also heard those same kind of stigmas associated with it. So, you know, we're sometimes called palliative medicine, palliative care, supportive care. They're the same thing. There's a big debate amongst the palliative care community of should we all go to supportive care? And people have strong opinions. I personally don't have strong opinions. I just want to do this good work. And if supportive care branding helps me get more access to my patients, then I'm happy to be called supportive care. I think it's more honest, honestly, like that's what I do. I support people on their journey, wherever that is.
So that makes a lot of sense. But, and I want to, because we do have metastatic clients, our stage 4 ladies here on as well. And so can you speak to a little bit about, is there any difference in what you would do for an early stage breast cancer for the metastatic, and maybe when do they know to, do they continue to get palliative care once they move into hospice care?
Another great question. Okay. There's a couple there. One is there a difference between stage 1 and stage 4 kind of care? The answer is sort of. Everything in palliative care is pretty gray. So both of them, you know, the first thing that I want to do is like make sure that we cover symptoms really well and try to like provide support in whatever stages are needed, right? So like pain, nausea, family, spirituality, whatever the things are. Once that's covered, with the stage 4, I would probably be doing a deeper dive into it. What where are we on that trajectory? Like how many, how are you doing functionally? Because some stage 4 women are, still quite functional, walking around, living a pretty darn good life and able to do a lot of things. And then some patients are getting towards the end of life where, it's really hard to get out of bed and get dressed because just fatigue and it's too much. So I want to know where we are on that trajectory, what the functional status is, and then also what is their support system like? Because for all people, pretty much, there comes a day when we can't take care of ourselves. And I want to make sure that they have the support that they're going to need on the next journey, because it really stinks when that day comes. But if you haven't thought about it, then you're having to do so much cognitive work at a time that's already emotionally overwhelming. And if we have some of those plans in place ahead of time of like, what would you want? Because it really varies. Some people say, I don't care what that means. I want to live as long as possible, even if I'm on machines, just keep me alive. And plenty of people say, no, I don't want any of that. If it's the end, then I want it to be peaceful. And so then where could that happen? Because some people have a really strong, big supportive family that, not everybody's working. And so they have caretakers in the home, and lots of people don't have that. And so these are the kind of things that we have to kind of start to explore and ask questions, hopefully in a really safe and supportive way that, we don't need answers to immediately. And I have a lot of my patients where it's just like, we talk about like, there's a box of like a bunch of scary things that we don't really want to talk about. And I ask them like, would it be safe to open the box and look at some of those today? And then we can put it away and we don't have to think about it. But I want to start making some of those plans so that it's not in a crisis if something were to happen and we've never talked about it. I don't know how to care for these people. I don't know what they would want. I would hate to be in that situation. I hate when I am in that situation. So I think that would be maybe some of the differences that people can expect. I think everybody, every single adult, cancer, no cancer, healthy, 18 and older, needs a medical power of attorney, especially in the state of Texas. And a medical power of attorney is just a person that, if something happens and you're not able to speak for yourself, here's the person that you trust to help doctors make decisions for you. So it doesn't have to be a spouse. It can be a spouse. A lot of people say, I absolutely want my spouse. And a lot of people say, my spouse just needs to like be able to grieve. And I really trust this friend over here to like make the hard decisions. And then not only do you want to identify someone, but you want to give someone like some guidelines of like, what does a minimal quality of life look like to you? And I think that everyone needs that just because, we drive on I-35 and like anything can happen. And they only go to the medical power of attorney if you can't make your own decisions. And so when I see it in cancer, a lot of times people are sick, they come in confused, they don't think straight, and we give them antibiotics, and then they're back to being their own like medical decision maker. So a lot of my patients tell me like, if I sign this, am I signing something over? And the answer is no. It's just in case, a backup plan. And then as soon as you're functional again, you're your own decision maker. So I have a medical power of attorney.
Completely agree. And just to put a plug in, we are going to do an estate planning webinar in April to talk about all of that. So we don't have any additional questions. I think I would just like to see if you can kind of summarize and what are some takeaways from today that maybe, the first thing, one of the things that they can do when they get off and just something that they can take away and put into place.
Yeah. So I would think that like some of the biggest things that I want people to know are that palliative care is essentially supportive care. And sometimes it's actually called that. And other times it's just what we do. So if anybody is talking to you about palliative care and they have worries that it means something different, know that that's not it. Know that it exists. And so if you yourself as a patient are experiencing stuff that your life is harder and you wish could be different, there might be a palliative care provider that can help you make some of those changes. So I think that those are kind of my two biggest takeaways is be able to know that it exists. You have a right to ask for it. I'm sorry that you sometimes have to advocate for it when you're already dealing with so much. And if you ever hear other people being worried about it, maybe you can help allay their fears. One last thing is, since Debbie just posted that she's actually in the hospital, palliative care teams often usually exist in hospitals. We're even more common in hospitals than in the outpatient setting. And so if you're ever in the hospital and feeling pretty miserable, that's another good time to say, do y'all have a palliative care team? Can they help me? Maybe we can.
Wonderful. Great. All right. With that, have a great day, everyone. We're going to sign off. Thank you again. And we'll see you again. Make sure to be on the lookout for our registration information for our April webinar. Thanks, Dr. Mills.
Bye.
Bye, everyone.